disabling?
Is just an emergency services worker in WA. I'm 35 years old. My first really bad experience with back pain was lifting this hose.
Whoops, sorry.
My name is Lawrence. I'm an emergency services worker in WA. I'm 35 years old. My first really bad experience with back pain was lifting this hose over this fence, and I just had this radiating pain shoot down to my. The first things I did is I just went through and got some physio treatment, and part of that was they just wanted me to get a really strong core. They wanted me to always lift with my knees and with my knees, keeping a straight back. And so I sort of started to get these seeds planted in my head that backs were kind of fragile, and that this is something that I needed to protect, especially if I wanted to work in my job for the next years plan. So I went to a chiro who was sort of doing all the manipulations, and one of the things he actually told me was that the only way I was going to get better was with repeated treatment. So he sort of put in my head that I needed intervention all the time. I went to a doctor and he referred me for an MRI, and this is where things sort of went kind of a bit downhill for me. I read the report, and unfortunately on that report, I'm seeing words like annular tears, bulges, fissures, and I'm sort of going, holy crap. What he said is, it's not a bad back for a 60-year-old. And that really put in my head that, I was aging before my time. It pretty much got me to a pattern of avoidance. So it made me think, okay, I'm fragile. What can I do to last as long as possible? I stopped doing any sports that would aggravate it, because I thought, my priority at that stage was lengthening my career. I was now preloaded with negative messages. I was preloaded to think that pain meant damage. I had this bad MRI. I had a bad back. I was fragile. I was broken. I was wrapped myself sort of cotton wool. I was just waiting for the next injury. So after the 3 years of being in this negative space, getting bombarded with these negative messages, I actually had a re-injury, which for my mental health, absolutely awful.
So that's Joe's story. And this is not an isolated story. This is a very common story for people with pain. Joe described that he had developed pain over a period of 3 years, that care was loaded with negative messages. He'd seen 2 physiotherapists who gave him these ideas that he had to protect his back, that he should sit straight, brace his core, be careful when he moves. He saw a chiropractor who said he needed lots of treatments, passive treatments, things done to him, manipulation, massage, to try and keep him mobile. He then ended up seeing a general practitioner who gave him an MRI scan that showed all the findings, like disc degeneration and fissures and arthritis, and he's told that he had a back of a 60-year-old. This was scary for him. He was given a bunch of drugs that were not very effective for managing his pain. And at the end of this, Joe was in pain. He was disabled. He was distressed. He was unable to do his job, and he had very little hope for recovery. So sadly, Joe's story is not isolated. We know that low pain leads to cause of disability across the world. So it's not isolated to Australia. It's a very common human problem. We see that back pain commonly begins during adolescence, and it rapidly increases through life. We know that in Australia, it is the leading cause of lost productivity, work productivity, early retirement, and income poverty. So it has a massive effect on people's lives. We look at kind of what is described here for lower back pain. We see in Australia, there's a lot of scanning done for people with back pain. But we know that scanning people's back can make them distressed. So people like Joe, because we know that findings on a scan are very common without pain, and they don't predict future pain. We see a lot of physiotherapists and chiropractors and massage therapists offering passive therapies or hands-on therapy or electrotherapy, which can provide short-term pain relief, but it doesn't provide long-term solutions. We see the use of certain drugs like opioids that are really, really risky and can result in addiction, but are no better than non-opioid drugs. See a lot of people functions which are very often not any better than a placebo and offer only short-term pain relief. And then when all this fails, often people end up having a fusion or a spinal surgery, which the evidence tells us comes with great risk, is often better than non-surgical interventions. And then we have an issue around what people's beliefs are about back pain. There's a very common view that low back pain is a serious medical condition. There's a view that low back pain will become persistent and deteriorate over time. There's a belief that pain in the back means that something's damaged, and so we need to scan the back to diagnose the cause of it. There is a belief that painful movements and activity should be avoided, and that back pain is caused by poor posture and a weak core. And so we need to be careful with our posture, sit up straight, and be careful how we bend. There's a belief that pain is a sign of tissue damage, and we need to rest them and protect the back for healing. And then there's a view that strong drugs and surgery are needed to treat back pain. Now, there's very little evidence for any of these beliefs, and sadly, most people originate from healthcare practitioners and clinicians who treat patients. So that means we have a massive problem in our own care professions where we don't understand the truth about back pain. Ask Joe what kind of messages he was given. He was told that his back was caused by damage based on the MRI scan, that he needed lots of treatment, that if it hurt, he should avoid it, that he was taught to protect his back by keeping his back straight, avoiding flexion, tensing his core, sitting tall. And when all of this failed, he was told he couldn't go back to his job. He described how this made him fearful of back pain and of damaging his back. He started to think negative thoughts, that his back was never going to get better, that he wouldn't be able to go back to his job. He lost confidence in his ability to move and bend and load his back. He became avoidant and overprotecting, tensed his back as he moved. He became distressed and anxious and depressed. Now, if we look at the evidence around all the literature for people becoming disabled with pain over time, we know that the things that often drive disability, pain over time, are exactly these things. Telling people that they're damaged and injured and that they will become disabled and that they may never get better and that there's nothing they can do to control their pain invariably makes them frightened. It makes them distressed, and it can make them depressed when they can't do the things in life that they love. This is often drives them towards protecting and avoiding and resting their backs and seeking passive treatments to fix their back. And these factors can set up a vicious cycle of combination of negative thoughts, negative emotions, and unhelpful coping responses that can make pain persist over time, and in many cases, years. So the common behavioral response to pain in this situation, if it's perceived to be threatening or damaging, is to avoid the threatening activity or to protect the back when engaging in the threatening activity. There's lots of research to show that people with back pain move slower and stiffer. They're more tense in their back and their core muscles than people without pain. Well, if we look at the story of people with back pain, they tell a number of about variants. They tell us that they feel damaged and that these beliefs around their body are informed by what clinicians have told them. They describe the distress and disability often linked to the care that they've been given. They often feel stigmatized and not validated. They describe the psychological and social impact of their pain, where pain becomes threatening, fearful, unpredictable, disruptive. where it impacts on their social functioning, their ability to engage in activities of daily living, this uncertainty for the future, and a loss of a sense of identity. They describe struggling with coping with pain. Strategies to control pain become vigilance, protection, identification. They have a sense of this sense of an assault on their self, linked to social withdrawal, pushing through, or this juggling act of pushing and avoiding. And then often leads a level of acceptance, which is often linked to despair, that this is their lot, that there's no way to get better. So cognitive functional therapy was an intervention was developed to help people like Joe bridge the gap. He was in pain. He was frightened. He was disabled, but he wanted to get back to work. He wanted to get back to activity. He wanted to get his life back, but he didn't know why. And so cognitive therapy helps to bridge this gap. It helps to coach people with pain to understand what's happening in their body and to find new ways of responding to pain so they can get their life back. It's a person-centered approach, so that the key around the care is around the person with pain. So importantly, cognitive functional therapy is aligned to best care principles. It's aligned to the care guidance. And when we're managing people like Joe, first we have to make sure that there's no serious pathology. Second, we need to screen for what are called often yellow flags or risk factors. And these are things like becoming frightened, having negative beliefs, becoming distressed over pain. The guidelines tell us that we need to provide education to people that is evidence aligned, and then target the physical and psychological barriers to recovery. Sadly, Joe never had any of that in his original treatment. Then, based on an interview and an examination of the patient that considers a whole bunch of factors, his physical factors, his social environment, his beliefs, his emotions, what's happening in terms of his levels of tissue sensitivity, his structure, and his health, we can then start to estimate what is going on with him. So back pain is not about this, it's about so many other factors will influence pain. And then based on that, cognitive functional therapy has three key pillars. It helps people to make sense of their pain through their own story. It guides them back to re-engaging in movement and activity with confidence, and it addresses lifestyle factors as well. So in Joe's case, after the interview and the physical examination, it became clear that Joe had avoided physical activity and he wasn't sleeping well. He was very protective of his back and very tense in the way he moved. He was only doing light work because he was frightened of doing heavy work. He had a belief that is damaged. He had a negative mindset. He was pain vigilant. He lost confidence in his back. This is largely due to the information and the treatment he'd had from clinicians. He was frightened. He was stressed. He was anxious. And he really said that he thought that his ability to exercise and to work was no longer possible. He was very sensitive to touch around his back structures and he was pain sensitive to move. Looked at our eye scan. He had changes on his scan, but for a 35-year-old, disc degeneration and disc bulges and annular fissures are very normal in people without pain, and they're not good predictors of future pain. So these are normal age-related changes. They're not a cause for his back pain. In terms of his health, he was fatigued, run down, but he had no other serious pathology. So if we look at this radar graph, we see that actually the thing that Joe had been told, that his back was damaged, was the one factor that had the least influence on his pain. The really big factors were he was become overprotective, he wasn't sleeping, he had this around back, and he had become distressed that had resulted in tension and loading and sensitivity of his spine that had then left him in this vicious cycle of pain and disability. Joe's goals were clear. He wanted to have control over his pain and he wanted to get his life back. So the first part of his care was to help him make sense of his pain. So in doing this, we then were able to sit down with Joe and say, look, you've got back pain, you've sprained back 3 years ago, but back's healed. What's happened is you've been given scary advice about your back. You've become frightened, you've tensed up, you've started avoiding stuff. You've ended up guarding your back and you become distressed. And this has set up a vicious cycle of pain and sensitivity and disability. But there's a new way. The new way is to understand that actually back pain is not necessarily a sign of damage. That if you different mindset, that your back is sensitized but not damaged, if you learn to relax and move it and engage in activities and movement and build your confidence and start getting active and start getting sleep and start to move again and get back to living again, we create a different cycle. And so in this way, we develop a personalized biopsychosocial understanding of his pain to build a positive mindset around his back. We look at dispelling myths. We provide resources. We share with people like Joe stories of other people with pain, evidence around the factors that are linked to back pain. We look at exploring new responses to pain instead of guarding and protecting, avoiding, to re-engage with movement and activity again. We look at setting goals linked to his valued activity. So for Joe, he wanted to get back to work. He wanted to get active. He wanted to start moving again, but he was frightened to do it. And so we start thinking about the facts around back pain. That back pain is very rarely a sign of a serious medical condition. That most episodes of low back pain get better. And if you don't get it, it's not really because your back is damaged. It's usually because you become frightened and overprotective and believe it's damaged. So low back pain very rarely means that the spine is damaged. And so scans are not needed or helpful for most people with low back pain. And it's important to tell people like Joe that if you scan 100 people with no back pain of his age, the majority will have stuff on a scan. The majority will have degenerative dysfunction, some fissures, and that is not a reason to avoid and protect the back. That avoidance and overprotecting the back actually delays recovery. That movement and activity and lowering the back, that actually movement is the way of getting better, not avoiding movement. That pain flares are normally caused by factors such as overprotecting and not moving the back, not through damaging the back. That strong drugs and surgery are very often not needed and usually are not helpful. So this is a completely different way of understanding back pain. And often this seems very strange to people because they're like, surely isn't true. Surely my back pain is different. Surely if my pain is this severe, there must be damage in my back to explain it. And so it's difficult when you're dealing with people like Joe. Make sure they feel validated, but you reinforce their damaged beliefs. So the way we communicate with our patients is really, really important. So the second part is building confidence back in the body, and we call this behavioral learning. So the first part of this is to make sure that people feel safe, that they trust us. And at the beginning of this, we often teach people to relax, and we will often do this through teaching simple techniques like breathing exercises. We stimulate the vagal nerve. They make people feel calm and relaxed in their body. So diaphragm breathing. And then gradually we will build movement back into the body and discourage them from protecting their back. So for example, you can see on the left, when Joe was bending over, he was keeping his back tense. He was putting his left hand on his knee. He was holding his breath to bend and reported pain. So we were able to take him through a journey of lying him down, teaching him to do some belly breathing, relaxing the back, then bring one knee up to a chest and then the other knee up to the chest, and then to take him to sitting and to get him to relax on his knees and to start to bend forward. And at the end of the session, teach him actually to relax and causes less pain, and it's safe and it's healthy. Now, of course, this can be really scary for people, particularly if they've been avoiding movement or the movements are painful. And so it's important that people understand that it's to do these things. And during this process, we call graded exposure to things, to the movements and activities that are painful and feared and avoided. And this seems counterintuitive, that actually you get people to do things that hurt them or the things that they fear or they avoid. But we know from a lot of research around fear is the only way we can overcome fear is to build confidence to do the things that we're frightened of. Ironically, Joe said that one of the things that was most important for him was the day when he was able to bend over with straight legs and a round back and lift a 100-kilogram load. Now, of course, that took months of training to get to that point. It was at the point he realized that it was safe to bend his back and he didn't need to protect it. So in this graduated way, we build confidence back in the body. The role of the physiotherapist is to act as a coach, encourage people to re-engage with the body in a normal way and build confidence. As soon as we start to do this, we then start to generalize that, so that then he starts to re-engage in the things in life that are important to him. So Joe was a firefighter, and so we had to get him fit again. We had to teach him to bend and to relax and to lift, to get back to running and lifting hoses and doing the stuff that he loved. And of course, this takes time. It can take months. So to build his self-esteem, build his confidence back in his body, to get him strong, to get him conditioned, and to chase the goals, for him to get back to work and to sport and to living again with the things that were most important to him. So then part of this journey was to get him back to engage in physical activity. And there's very strong evidence that physical activity is like a drug, that engaging in activity based on the preference, and it doesn't matter what it is. It could be going for a walk, it could be riding a bike, it could be dancing, it could be yoga, it could be Tai Chi, it could be a number of things. But to engage in regular physical activity has huge benefits for a person's confidence, their well-being, their mental health, and it also reduces pain. And there's a minimum dose. So essentially engaging in at least 150 minutes a week and gradually building it up. So of course, Joe couldn't run at the beginning. He started to walk. He was able to get on a bicycle, an exercise bike. And with time, he got his legs strong, and then he was able to get back to doing what he loved, which is involved running. We also look at other lifestyle factors like sleep. And we know that there is a strong relationship between broken sleep or poor sleep and sensitivity of the back and inflammation in the body. And so getting people into regular sleep habits, teaching them relaxation techniques like breathing techniques before sleep so that they're not tense and anxious in bed, teaching them to relax their body in bed when they roll and move so that they're not clenching their back as they move. And then so part of this is teaching relaxation techniques, because we know that pain and the pain is threatening, it can trigger a stress response in the body. And so the body goes into like a fright response where we clench our muscles and we have adrenaline in the body and we sensitize the system. Relaxation techniques tend to trigger or activate the vagal nerve that brings calm and relaxation and desensitization to the body. And they can be very effective for pain relief. One of the real challenges working with people like Joe is to communicate with doctors, because often the messages that they get from their doctors are around your damage. There's something on a scan, you need to fix it, you need to protect it. And we know that these beliefs are not just problems in healthcare practitioners, they're problems within families. And where we see often a contradiction where people in society have this belief that back pain means you're damaged and that you need to protect it. So I'm seeing brain start to communicate with patients and to say, I want you to move. I want you to get active. It's okay to move, even if it hurts. It's safe and it's beneficial. And often you'll see this process where people start to increase and they decrease pain over time. But that's why when we communicate with other care providers, we have to have a common understanding. We need consistent messaging. We have to have shared values and common goals. So for Joe, it's stress to get back to work and to activity. Now, we've done a number of trials, and our group has done a number of trials in cognitive functional therapy. There was a trial conducted in Norway a number of years ago, another trial in Australia, and was a trial Mary O'Keefe was conducted in Ireland. And then there have been 2 trials in Denmark. Now, these trials were relatively small trials of between 2 and 3 physiotherapists compared to other physiotherapy interventions, but there were no comparisons to usual care, and there have been no economic evaluations. So these trials show that there are significant benefits to cognitive functional therapy compared to other physiotherapy interventions, with reductions in pain and disability over time. So it was time to do a big trial, and we had this trial that was published in the journal The Lancet this year. So this was the 2-center trial. There was a group of 2 centers, one in Sydney in the east of Australia and one in Perth in Western Australia. We took 18 physiotherapists who'd had very little exposure to cognitive functional therapy, and we trained them to deliver the intervention over a 6-month period of time. So this intervention was a multi-stage process. The first part of the intervention was we taught them about, we gave them a knowledge session. So 2 days, we taught them about the evidence around pain. We taught them how back pain very rarely meant that the back is damaged, that the factors that drive pain are things like fear, the things we've talked about today, becoming frightened, becoming anxious, overprotecting, avoiding. To help people understand that, we also taught them about cognitive functional therapy and how to grade that to help people and apply that to people like Joe. The second workshop trained skills. So these communication skills of communicating with patients in a way that help them understand that they feel validated, and to look at ways of motivating them to start to change the way they think about their back. These skills are also related to communicating with that, the way they move. So what we would call exposure techniques of teaching people graduated ways of moving and re-engaging in movement in a relaxed way. Then the subsequent 3 weekends, we directly mentored the physiotherapists while treating patients with chronic low back pain within a small group. And we provided feedback to the physiotherapists to teach them how to work with patients who are disabled or distressed. And at the end of the 6-month period, we did a competency assessment where they had to assess a patient and treat a patient in front of us. And then we were able to rate them based on whether we thought they were competent to deliver the intervention. Now, 2 people were not competent, and they were given an extra 6 months to resit the exam, in which case they did. But at the end of the period, 18 physiotherapists entered the trial. So half of them were in Perth and half of them were in Sydney. So who were the people in this trial? Well, we had about 500 people with chronic low back pain entered the trial. The people were over 18 years. So we included any of the 18 years of age who didn't have any sign of serious pathology. So there were no fractures, cancer, quarter equinus syndrome. So we excluded people with serious pathology. These people had pain for an average of 4 years. So some had back pain for many years, but the average was 4 years. The people in this trial were more disabled than most people in previous trials. A number of them had other health comorbidities. A number of them had spinal surgery, and a number of them had mental health challenges. And we know that mental health problems and back pain are very commonly comorbid. A number of these people had so much treatment that was given up on care, and they thought that living with disabling pain was just something they had to accept. We had 3 treatment arms. We had a CFT group only, as cognitive functional therapy group only. And these people were treated up to 7 treatments over 12 weeks. And then they were given a booster session 6 months, after 6 months. We had a second group, which was cognitive functional therapy, plus the addition of movement sensors. So these sensors put feedback on an avatar, on an iPad, that allowed people to see their bodies move or their back move over time. We would then program these sensors to give these people feedback across the day, to give them factors to how they move, the speed at which they move, and their way in which they postured their back. So we were interested to see whether the addition of movement sensor biofeedback actually augmented or improved the effect of cognitive function for the patient. The third group was what we called usual care. So there was no restriction of the care for these people. And a number of these people were taking medication for their back. They're seeing the general practitioners. Some of them were seeing physiotherapists who were getting hands-on treatment for their back. A number of them were also had given up on treatment. And this is quite consistent with other studies that have explored people with chronic low back pain, that there is a mixture of care seeking in this group. The question we had in this trial was, does cognitive functional therapy add anything extra to usual care for people with chronic low back pain? That was the question we asked. So this graph here figure is pain-related activity limitation. So this is related to disability. And what you see here in blue, there's a slight improvement over time of the usual care arm. But you look into the green, these are the cognitive functional therapy group and the cognitive functional therapy group plus biofeedback. You see there's no difference between them, but there is a significant improvement, like a 50% improvement in their redundant disability over the 12 week period. The 12-month period. Now, this is not that common in back pain. To see effects this large and to see them sustain at 12 months is unusual. So remember that the intervention period finished here. There was a follow-up at 6 months, but after that, they'd had no treatment. In actual fact, when we look at clinically important differences, that the CT at 12 months, 70% of people had achieved clinically important differences compared to only 24% in the usual arm. So these are large benefits for people in this group. And importantly, that benefit sustained well into the intervention period. When we looked at pain intensity, we saw the same thing. So you see just a slight improvement in pain intensity in the usual care arm, but we saw significant reductions in pain intensity in both the cognitive functional therapy and the feedback as well. When we look at clinically important differences, we see that there's a double of the benefit of people who achieve clinically important differences for pain reduction in the CFT arm compared to the usual care arm. When we looked at the economic evaluation, we found that both the CFT groups saved at least $5,000 per year compared to usual care. So this was mainly in terms of improved participation in both paid and unpaid work. So we found that people in the CFT group actually went back to work or engaged in active work again compared to the usual care group. And of course, this represents huge savings for society. When we looked at other measures, we found that the people in the CFT groups were less frightened of movement. And you see this here compared to the other usual care group. We found that they had lower pain catastrophizing. So they weren't thinking such bad things, such as, I'm never going to get better. There's nothing I can do about my back. Back pain means that I can't engage in an activity daily. So they had a more positive mindset. And they were more confident. They had higher levels of pain self-efficacy. So they were more to re-engage in activity. So they were more confident to re-engage in activity and movement. Now, this is important because what we're seeing is everything we measured changed in this group, and the change was sustained at 12 months. That's why I'm very confident with the results of this trial. When we asked people how satisfied they were, we found that 84% of the people in the CFT group were highly satisfied, or satisfied to only 17% in the usual care group. Importantly, the other thing is we found that the intervention was safe. When we asked people to go back to do activities that they previously avoided and that were painful, not only did it reduce their pain and disability, but there were no increase in adverse events or serious adverse events in this group. Now, that's important because people often think that getting people to do activities of daily living that they avoid or that are painful is dangerous and should be avoided. But in actual fact, we found it was beneficial for people. As you can see in the graphs, there was no additional benefit from movement sensor by feet, but the sensors add to the treatment effect. And that's good in some ways, because it means you don't need the use of technology to teach people. You can use feedback using the likes of mirrors and demonstration. You don't need expensive equipment to do that. Now, this is just from the patient's voice. We interviewed a number of people who had been through this intervention, who had previously had disabling low back pain, and asked them what they thought happened in their journey. They described that their journey began often with injury or stress or fatigue where they hurt their back. They described how they had these experiences with healthcare, with this negative message about the body, failed treatments. They often felt unheard and dismissed. They ended up feeling stuck with pain, distressed, frightened, tense, weak, and vulnerable. When they entered the trial, they brought their story, brought hope, they brought courage, they brought a desire for partnership. They wanted to get on with their life. The clinician brought kindness and empathy, listening, and a willingness to partner with the patient, to act as a coach, not to fix them, but to coach them and guide them. They described how their story had been heard, that there was time and space to tell their story to the clinician. They described becoming aware of their body, of learning to relax and move without protecting their body. They described that they were helped to make sense of their pain, to understand how their thoughts and emotions and stress and behaviors and body responses affected their pain, to understand pain is an accurate sign of damage, that often you can get serious pain without damage. And then they learned to develop control over their pain and confidence to relax and move and get back to living again, to engage in a healthy lifestyle, exercise, to sleep, to get back to engaging with other people socially. But they often describe challenges and flare-ups along the way that they had to negotiate, and describe the importance of working with the clinician to confidence so they don't go back into overprotecting their back and fear again. And they describe this process of eventually, over time, getting back to living. And for some people, this could take 3 months. For others, it could take 6 months, 12 months. But the key with this is they learned to become independent. And they often describe growth in other aspects of their life. It didn't just help their back, it helped them in other ways. Now, there are lots of roadblocks for providing this kind of care. Some of these relate to our own traditional roles and training and our own beliefs about pain and our own professional identity. Physiotherapists often feel more comfortable to lie people on the sofa and to massage their back or to do something to them rather than to coach them and to educate them. And so training is required to deliver this kind of care. People often find that if they don't have peer support or they lack confidence, it's hard to deliver this kind of treatment. And of course, issue patients' beliefs and expectations. The patient may come to us and say, we want to be fixed. We want to lie on the bed and we want you to do something to me. but I don't want to be actively involved. And this makes it very difficult for some people to have access to care because they can't afford it. And for other people, they have a whole lot of other stuff happening in their life that makes engaging in this kind of active intervention difficult. Then in Australia and other parts of the world, we have these problems with funding, where often there's funding for very expensive treatments like injections and surgery, but not for interventions like cognitive functional therapy. We have a health care system that doesn't give sufficient time to educate people or to mentor them. And often we have a healthcare system where the messages that are given to patients are very confusing and contradictory. And then, of course, we have a society where often we have these beliefs around pain, we have this idea we want quick fixes, that we don't want to have to engage personally within the process to manage our pain. So there are lots of roadblocks to where it's difficulty of managing people like Joe. I think a number of things that have to happen to improve the lives of people like Joe. We need to educate people in society. We need to upskill clinicians. We need to educate them better about back pain. We need to educate them with skills to communicate, skills to coach, skills to build confidence back in patients, to empower them, to get them, to make them believe that they can re-engage with their body in a way that is safe. We need to make sure that we communicate with our healthcare professionals so that we don't create division and conflict. We need standards of care, which can help direct care in a way that we know what is good care for people with back pain. You need funding models to make sure that we adequately fund that care, and we need implementation research to test it, and in different countries. Now, if you're interested in this work, we have a website. It's restoreback.com. If you're interested in further information about this trial or further training in this approach, then I encourage you to go to this website to register your name on it, and we will communicate with you when opportunities arise. There are some amazing resources on this website. There's a whole description of the trial in it's a very easy language. And there's a whole bunch of videos of people like Joe who are. So I just want to highlight, this is the trial, the clinical trial, and a number of collaborators as well, part of this trial, and particularly Peter Kent. He was the lead author of this trial, as well as a bunch of our collaborators in Perth and Professor Mark Hancock in Sydney. Now, I just want to check. Just make sure that I don't think, did I play this video? I think it jumped past it.
So after the 3 years of being in, after the 3 years of being in this negative space, getting bombarded with these negative messages, I actually had a re-injury, which for my mental health was absolutely awful, but it meant that I sought a second opinion from a guy that came recommended to me actually earlier. So I was in the first consultation with this new physio, and I mean I'd had all of these. I was now preloaded with negative messages. I was preloaded to think that pain meant damage. I had this bad MRI. I had a bad back. I was fragile. I was broken. I had all of this negative messaging that was in me, and in the very first session, and so I was at rock bottom anyway. So I walked into this session, and the physio's, he introduced himself, and he's had a bit of a laugh, gotten to know me. The first appointment was quite long because he got the full story of how I'd gotten to, which I think was really important, because without that building of that initial rapport, like what sort of came next was something I never would have been able to swallow. So the first thing he did, he got me to bring my MRI in, And as opposed to the first doctor that said, this is a great back for a 6-year-old, he's just thrown it out and gone, yep, all normal age-related change. So the first thing was that, boom, completely disregarded that damaging report from my MRI. And then he just started getting me to move. So instead of avoiding movements, he got me to start actually doing movements and reinforcing that movements were safe, movements were actually good for me, that any pain that I was feeling did not mean that I was damaged, and that pain can actually happen apart from it have to mean that there's damage there. So he just reassured me that any pain I was feeling was normal, and actually that the pathway through it was to gain confidence, was to actually move in a natural way, and the thing that I was safe, and that I actually was going to have, and I wasn't actually damaged, which I think was a huge part of it. Mate, it gave me life back. I can't even explain how happy that made me to get back on track. So, I mean, every single message up to that point had been negative, but then now all of a sudden I was getting things back. So essentially I brought a list of activities to the physio, like, this is what I've stopped doing as a result of my pain. And went, yep, you can do that, you can do that, you can do that, you can do that. And surely one after the other, he took what was important to me and actually made that the goals of my rehab program. So it was very tailored.
So that's Joe's story. Now, I think we have time for some questions.
Thank you, Peter, for such an elaborate and such an enriching discussion and sharing your experience also along with the parents. I'm delighted to share that the response to your physiotherapy lecture was amazing. We had not only Indian physiotherapists who were very interested. I was surprised to see we had physiotherapists from more than 16 countries registering for the webinar. And I see there are more than 10 countries who are here, who are listening to you live. About 100 here, almost 100, and more than 100 on live on YouTube. We had slight difficulty in the beginning where we had some glitch, but everything went. So while we wait for our audience to ask few questions, I have one for you, if you may allow me to start with.
Sure.
So how often do you take interdisciplinary approach treating low back pain in Australia and your home country?
Yeah, it's a really good question. So I work in a primary care setting, which is, we have one pain psychologist, but the rest are physiotherapists. We have a small group of patients who are really and have other mental health challenges. We work in conjunction with a pain psychologist, but the majority of people we see, we would manage independently. So if a person has really severe pain, or we expect serology, we would of course communicate with the general practitioner, or we would send them for imaging. So in the case of serious pathology, we would work with the general practitioner. Of course, we communicate with the general practitioner around the care of the patient they refer to us, and in a small group of patients, we work with pain psychologists.
Great. And this is related to what I have studied in my doctorate program. Do you really believe the attitude and belief of physiotherapists, it matters while they treat the low back pain patient?
Oh, 100%.
So what are these factors?
Absolutely. Absolutely.
What are these factors commonly you have seen in Australia? Is it the...
Oh, look, I think what's happened, I think historically we've been trained to think of the back as a structure, and not to see pain as something of the part of the nervous system, and to think of pain as something that's wrong with the structure of the body. And so we need to fix the structure. We have a fundamental belief in that. I think around, not everybody, but I think that's a very common belief. And so if people have pain and the pain is severe, we think we need to identify the structure. We need to protect the structure. We need to let the structure heal. And so we need to rest, happen. But what we know now is that very rarely is back pain related to tissue damage. And so the worst thing we can do is to protect it and avoid it and rest it. We need to move it and use it and engage with it. This is consistent with sports medicine as well, that we used to think that if you had a sprain that we should protect it. We know we shouldn't do that now. So backs are no different. And unfortunately, I think that's taking a long time to change, that understanding, and that's still within our practice. We see a lot of physiotherapists who I think are frightened to get people to move if they have pain. We often buy into our patients' distress. And so it is more about our distress. It means we be careful when we get people to use their bodies, but we need to be confident that the human spine is really strong, that if we want to make people healthy, we need to help them to move. We need to get them active. And that is the way forward. You have to be brave. And that will take time. It takes time. And that's why it takes training. So we had people in our trial, some of them had been trained for 30 years, but they took time to retrain in this approach because they had that old mindset. So it's a lot about our mindset and behaviors that we often transfer to our patients. And that's something we need to change.
Great. We have a few questions from our president, Dr. Raju Parashar, although he's here with us, but I also know that he's traveling in mountains in the United States currently, which is early morning. So he wants to ask you, what about the acute flare-ups? And would CFT work for the cognitive functional therapy?
Absolutely, yeah. So we saw a number of people in the trial with acute flare-ups, and we have found in the qualitative studies that managing a flare-up is probably one of the most important learning occasions for patients, that actually understanding that a flare-up doesn't mean you're damaged, and that relaxing and moving and re-engaging with activity is really important for recovery. Because people usually, when they have a flare-up, go, oh, I've got to stop exercising, I've got to stop moving. But we would say it's even more important to exercise and move when you have a flare-up. So managing those flare-ups, from what we've seen in our qualitative research, is particularly important. And all the people in our trial were given a flare-up plan. So they were told, if you flare, instead of protecting your back and avoiding movement, we want you to relax and move and get active as quickly as you can.
Lovely. Another question, what he has shared with me is overcoming the psychology of patients who want passive hands-on treatment. What do you have to say about it?
Well, in our trial, we use none. There's no hands-on treatment in this trial at all. So we can say that these results are not a result of hands-on treatment. These are a result of people who have been coached. Now, importantly, in this study, a lot of these people had hand treatment and it hadn't worked. So it doesn't make sense to do more of something that doesn't work.
Okay, and the last one.
And the other thing that's important is that hands-on treatment are often a distraction from the main game. I often say to my patients, I can do something to make you feel good, or I can teach you to do it. I had a man today who said, you're unusual. You're like no other physiotherapist I've seen. Most physios lie me on the bed and rub me. Don't do that. Why is it? And I said, because I can get you better faster by doing this. What do you want to do? He goes, I'm happy with that.
Another add-on to this, what he has told me to ask you about is how what if we combine CFT with passive movements?
Yeah, the question I would say is if you want to empower people, so if you want to empower people to take control of their pain, show the things they can do themselves at home. Making them reliant on us is not a good way for healthcare. We want to empower people to feel confident in their body so they don't feel like they depend on us. The whole idea of building efficacy is that they are the people in the driver's seat, not us. And I think too often in healthcare, we think we're driving the bus. We want them to drive the bus.
And another interesting question, what my colleague Kalpana has asked me is like, what's your opinion about the chiropractic approach towards low back pain? I mean, or any other pain for a matter.
Yeah, so it depends. And so with chiropractic, there are different schools of thought. So there are some modern chiropractors who are very sensible and evidence-based, but there are other chiropractors who x-ray people's backs and tell them that they're bent and out of place and that cracking their back puts their back in. That is not evidence-based. And so if that's the kind of chiropractic that a person's getting, and look, physiotherapists do this as well. I've come across physiotherapy, patients have been told by therapists that their back's out of place and they need to straighten it up and put it back in. That's not evidence-based care. And so I think we see that in lots of professions, we have care that is not aligned to the evidence. And rather than identifying a profession, we should identify a practice that is not evidence-based.
Yeah, absolutely. We have another foreign guest who wants to ask you, how about low back cases with neurological deficit? Do follow the same concept when applying CFT? Or do we have different?
So back, what was that, sorry?
How about low back cases with neurological deficits? Do we follow the same concepts?
No. So what I said at the beginning was that with cognitive functional therapy, we first screen. So if the person has suspicion of cancer or infection or an inflammatory disorder, or they've got nerve compression, that's a serious, that sits in the serious pathology group. So if the person has progressed neurological deficits or Cauda-Equina syndrome, we would refer them for a medical review. But if they have leg pain and absent neurological deficits, or the neurology is improving, so the natural history is for improvement, then using these strategies can be helpful. But we have to be very careful that we discriminate between pain related to pathology versus pain that's not. And the majority of back pain is not. It's a small group where it is. And so we're very careful to screen those people out so that we didn't include them in our trial.
Okay. The another question we have with us, it's a long statement before we make a question. He said, we talk about people who live in sedentary life and have a very weak muscles. Can we say that all facts that we know as right position for lifting, the right position for sitting, and the right position for pitch something for the ground is wrong? You can take comfort position they always use.
Yeah, so there's a lot of thoughts in that statement. The number one is being sedentary is bad for your back, but the way you lift and the way you sit, there's not much evidence to say that there's good and bad ways to do it. The key thing is vary your posture, change your posture, move. Movement is the key for the health of your back. So engaging in movement and activity is really important. Being sedentary is not so good. You could be sedentary in a variety of postures. It's still not good. And so this idea of there's a posture for your back, we don't have good evidence for that. But we do have good evidence to say that our backs, to stay healthy, need to move and we need to stay active.
Lovely. Another colleague of ours, Dr. Prakash, has asked, what's the approach you use to make patient believe that moreover need communication and counseling as in CFT regarding their body?
Yeah, it's a great question. So we tend to use behavioral learning as the most powerful way to educate people. So what that means is a person is frightened to bend. So I had a lady in today who a week ago, she's had 4 years of back pain and she hasn't bent over for 4 years. She believed that it would damage her if she did. Across the first session, I taught her to relax and she touched her toes. A week later, she's now bending and she has less pain. So I don't have to educate her that bending is good for her. Spirit is that bending is good for her. So it's actually through her own experience that she will change her own beliefs. And so we use these experiences, or what we call behavioral learning, as the most effective way to change someone's beliefs, not lecturing them.
To practice CFT, whom we have to change first, the therapist or the patient?
The therapist, 100% the therapist. Yeah. And that's why we spent 6 months training the therapist, because and there's a paper, if you're interested, I can send it to you, which talks about the therapist's experience. And they felt like they had to do a behavioral behavior change intervention themselves. They were saying, we've done CT on us first before we do it on our patients. So they actually felt like they had to change their own mindset and behaviors so they could help the patients. And so often we need to intervene in ourselves before we intervene in others. And that's why training is so important in this approach, that it's not just enough to read an article or listen to a lecture like this, that actually we need to upskill people to learn the skills and knowledge and then develop the confidence and competence to apply this intervention effectively.
Great. Thank you. Thank you so much, Peter. I know the question and answer session will go on and on. It's almost going to midnight at your place. So my last question to you would be, I think, just to wind up with that, do you offer your courses with an online mode as well, or it has to be on face-to-face?
No, we're actually at the moment developing an online platform, which will because we realize we've had a lot of requests around the world. And so if any of your listeners are interested in that kind of online education, because we realized it's expensive to travel. It's not good for the climate either to do too much traveling. But actually, you know, one of the things we learned during COVID is that we can educate people like this through Zoom forums, through webinars. And so we're looking at developing material that can be training opportunities will be online. So if you have people who are interested, that website, restorebackpain.com, if you register your interest, then we will communicate with you in terms of when opportunities arise.
Great. We look forward to hearing from you. With this, we come to an end, and I know you are getting ready for your 3 weeks track to Nepal in the month of November.
I am. Yeah, I'll wave to you from 5,600 meters.
Great. That makes us feel jealous. Anyways, our invitation, we look forward to have you in India soon. I'm sure we will have that great occasion where our Indian physios will also be benefited with your work, and our invitation for you to come and join us for our 8th annual conference next year, or maybe the 9th one next year. We will
maybe not the 8th, but I might be able to do the 9th. I mean, I would love to come to India. It's one of the countries in the world I haven't been to, and you have such rich culture. My wife's traveled through India and she has wonderful memories of it. I've been to Bhutan, I've been to India, I've been around India. I haven't just quite got to it yet, but I'd love to come sometime.
You will be surprised looking at how many fans you already have in India who are actually trying to practice that experience. So look forward.
That's nice.
With this word, we come to the end of this lovely session. I, on behalf of our president, Dr. Raju Parashar, the entire governing body, the founder member, and the members of Society of Indian Physiotherapists, and all the delegates who are listening to us at Zoom Room and also at YouTube, sitting at various parts of the globe, thank you for sharing your experience and taking us to a different level in treatment towards low back pain so that we can really make a difference in our patients' life. Thank you very much once again. And we say namaste to you when we start the G20 Summit tomorrow at New Delhi. Looking forward to host you also in Delhi or in some other city. And thanks to each and everyone who joined us for this online session. Wishing everyone a very happy World Physiotherapy Day. May we keep helping every patient of ours to make a better life. Thank you so much and look forward to see you soon sometime. Thank you, Peter, once again. Looking forward.
Thank you. And thank you to everybody for joining in. I'm sorry I can't see your faces. I see lots of names, but no faces. But it's been a pleasure to communicate with you. Thank you.
Thank you, everyone. Thank you.